Can you hear us? Dr. Saad, can you hear us?
Stricture, ERCP has been done, stent has been placed. CT scan did not show any mass in the pancreas or any, so we are trying to find out. Her CA199 was normal, and so we are just proceeding. So we've got liver, right? So you've got tip up, right? जहाँ पे आप पहले थे, that was nice, right? Just advance your scope a little bit.
Dr. Saad, can you hear us?
Yes, I can hear you.
Sorry, we couldn't hear the history.
Okay, 48-year-old lady with distal CBD stricture, ERCP done, stent placed, CT scan not showing anything, CBD or no pancreatic mass, CA199 normal. So we are doing this to find out why she's got distal CBD stricture. Okay, so what are you trying to find out? Now you've got liver, so you want to rotate. Yeah, keep rotating, keep rotating, keep rotating. थोड़ा सा pull back करना पड़े. You are rotating, but that's not rotating पूरी तरह से ना. So keep going, keep going, keep going, keep going, keep going. So we've seen the liver in that process as well. थोड़ा सा अंदर जाके, just advance a little bit. Now rotate clockwise, anti-clock, sorry. Yeah, anti-clock. Keep going. Yeah, keep going that side. Keep going that side. Keep going that side. Keep going that side. Keep going. Go more, I'm sure. थोड़ा सा आप अपने आप को distance पे करें. You should be able to go more if you. You can go all the way. And you should get the aorta somewhere. We're already seeing something there, but we want to find aorta, right? There are some lymph nodes there that look very suspicious. You can see the CBD and the stent here, right? एक सेकंड में दिखाएं तो मैं आपको वो चीज़ जो आपको करनी है दिखाऊं. So go in. Tip is up. Almost. You asked me how much. Almost. And I rotate. Bas maybe 2 minutes. This one we are doing under sedation, so back a little bit. There you are. Okay? That's your aorta. So now if I go back here, that's your liver. Okay? Right? We are at about 40 centimeters, so 5 centimeters into the stomach. The women, usually the geojunction is at 35. So go 5 centimeters, gently anti-clock rotation. We have both the vessels, right? So we have the celiac takeoff there, and we have the superior mesenteric. So if you want to take back and try and do that quickly. अभी हम पैंक्रियास की तरफ नहीं जा रहे, अभी तो हम सिर्फ फोकस कर रहे हैं एओर्टा पे. ठीक है, अब एओर्टा आ गई ना, अब पैंक्रियास की तरफ हमने जाना है. So that's your celiac artery. So I'm going to follow this celiac artery. ठीक है, you can see it. We are still following it. ठीक है, that's the splenic artery. So I just keep following it, and we should be hitting the pancreas there. Okay. And then here. अब इसमें अब आप एक दफ़ा पैंक्रियास को सेंटर में कर लेंगे. So if you go anti-clock, you should go towards the neck, and if you go clock, you'll go towards the body and tail. So we've got the so we're gradually going towards that. We get little shade of the left kidney there, and if I keep going a little bit more, you'll be seeing the spleen in a bit. So your tip up is important. There you got the spleen. ठीक है. This is a big subject, so sometimes you can't see things as clear, and you just saw the adrenal as well. Our area of interest here is D1. So let's go to D1. Could you guys see and that?
Yes, we can see.
बस बीबी थोड़ी सी तकलीफ होगी. Need to keep talking to the patient when they are sedated. Okay, that's fine. So you come back a little bit, and now anti-clock a little bit, tip up. Excellent. Yeah, you've got portal vein, you've got splenic vein, right? You've got the portal conference, so now you bring it down a little bit. You've got portal vein, that's superior mesenteric vein. So, clock or anti-clock, whatever you want. This way, you will be going towards the hilum. If you go clockwise, you'll be going. But before that, we need to find out where the. So, थोड़ा सा आप अपने आप को adjust करेंगे with moving the scope, pulling back, slightly, probably falling back. There you are. You saw that. So you need to. It's just subtle movements will bring the bile duct in your view. So try and do that. Tip up. Right. Portal vein hai. Upar no. That's probably GDA. Yep. That's a vessel, okay? So अभी आपको CBD नजर आई थी. It's a very big CBD with a stent in it. No, it's very big. You can't. You missed it. आपने देखा नहीं, but you need to keep an eye. Just move now, subtly. Yeah, and move the other way. थोड़ा सा tip up करें. Advance करें. Yeah, keep going. Keep going. Back a little bit. You're not seeing that. एक सेकंड दिखाएं, मैं आपको बताऊँ आप क्या मूवमेंट करेंगे तो आपको मिलेगा. Because I'm not sure why you're not getting it. So we'll just go up, tip up it. Okay. Trying to see where we are. एक मिनट है. थोड़ा सा अंदर आ गए, right? So that's the reason. So you need to just check. As soon as we are in the right place, there's your portal vein. That's your CBD. You can see the CBD with kachra here, and we should. Huh? So let me bring the cursor. So air out, and we've got so that's the CBD there. That's portal vein. Okay, and we'll just try and see now. All I did was, what happened was you fell back into the stomach. So if you're in the now if you're in the bulb, I'm just going counterclockwise, and you can see the stent there. You can see the liver coming there. So if I pull back a little bit, I'll see that duct going towards the liver more. If I follow it down this side, which is clockwise, I'll take it slowly towards the duodenum. Okay, so that's almost, there's the pancreatic duct. Can you see the pancreatic duct? Okay, now you take the scope quickly and have a look. That's the pancreatic duct, that's the CBD. Okay. And that's the fall off. So we've almost reached this area. PT is okay, but this is not normal. If you remember what Dr. Khalid was saying yesterday, you can't see that. So distal CBD doesn't look normal. Okay. Now you can. So all you need to do is in the you've got your tip up in the bulb and we will straight away hit this. Pull up in there. काफ़ी थोड़ी सी जगह होती है, but you can do this as well and then bring it down a little bit. ठीक है, if I want to, अब ये देखें, अब आप उसको थोड़ा सा रिलीज करेंगे, बट ये जगह तो आपको मिल गई ना, मैंने फुल किया हुआ है. सो यू कैन सी वेरी नाइसली, दिस इज व्हाट, कौन सा वेल साइन होता है ना, so you can see the splenic vein नीचे से superior mesenteric vein coming from the right. This is not seagull is for that. This is the whale. कौन सा whale होता है खालिद? They call this some whale sign, right? I don't know. Yeah, what, because they've got that thing. This is CBD. You can see the stent there. Yeah, there's a lot of sludge, but Khalid, when we go down, just the distal end, as I go down here towards, so you can see that. Yeah, so that didn't look good, but अब आप थोड़ा सा देखने पे मैं अपनी टिप अप करने इसी and just keep going anti-clock. Pull your scope just a centimeter back. Just advance your scope again a little bit. ठीक है जी, तो समझ में आया? तो अब आप वापस जाएं. लेट हाँ, स्टैंड ऊपर है, थोड़ा सा पुल बैक करेंगे. When you pull back, your subject will come from the left, where it's out towards you. You advance the other way, it will go. In this situation, but you've lost the thing now. I'm not sure whether you're still in the duodenum or have you fallen? I know, but are you?
Dr. Saad, there is a question here.
Yeah.
If we think that this is
go down to the D2P. Yeah. Please go ahead.
If we think that this is a malignant looking stricture,
yeah.
We haven't seen a lot of lymphadenopathy. Is that normal in distal CBD strictures?
There was some lymphadenopathy when we were in the stomach. I don't know if you noticed that or not.
I don't think we saw it.
Okay, so I thought there was some abnormality when we were in the stomach and looking at the pancreas, so I'm not sure about that. But that time we were, bas a pull back. So, do we always see lymph nodes? Yeah, you are falling back. So let me just take over here. The patient thoda sedation and so I'll have to take over. So you don't really have to bend down. You go in. So this, use my big wheel the other way down. So I'm not going to bend down or do anything. You don't have to do anything. You just need to pull yourself back. Okay? So once we've done that, we are now in the D2. एक दफ़ा आप वहाँ पे आ जाते हैं तो you should be able to see. Again, we'll have the tip up and we'll start looking for the aorta or the IVC. Okay? So the way you do that, the way I do it is basically just pull back, tip up, and we have a structure here that I can see already. अभी तो मैं राइट किडनी को देख ही नहीं रहा, but I know that this is a vascular structure यहाँ पे, ठीक है ना? So right kidney is a bonus. We really don't have to see it. Okay, so we have some vascular structure here, but there's a lot of debris here. Yeah, even though there's a lot of inflammation here. So we saw one lymph node there. We can't be, this is not malignant looking for sure, but can you see the lymph node?
We see the lymph node.
I don't know if these guys can hear me or not. So we start seeing air here. Can you see the air?
Yeah.
Okay. The CBD there. If that's the CBD, this has to be consonate here. So we've got the stent, so I let go of my big wheel a little bit and we can see the stent here. So we'll try and see if we can bring it a little bit more straight. And so what I'm doing here is basically just moving just torque left and right. Nothing else than a slight movement, very slight movement to see if I can get things where I want. So my tip is up and basically this is, so that's the pancreatic duct if you can see that. Can you see the pancreatic duct now as well?
Yeah, we can see pancreatic duct.
So that's the pancreatic duct there and that's the CBD there with the stent in. There is no mass here that I can see going towards the ampulla. Okay, sure. So I can't see anything here in the uncinate. Okay, I can't see a mass here, or this would be the ampullary area, right? And again, the ampullary area doesn't do. This is the duodenum there. You can see air and debris there, and this is what you do. You see, the thing is, yes, there is inflammation here. This is a little hypoacousticy you can see there. But then you've got a stent here. So when you have stent here, you really can't be, you can't say for sure that this is something that's pathological here in terms of malignancy or not. I am not convinced that that is. So that's how you look at it from duodenum. So we've looked at the uncinate here. We've looked at the bile duct with the stent in it. We've seen the pancreatic duct going. There is no pancreas divisum here. You can see the pancreatic duct going that way. I only saw one area in that. I want you to just feel this. Leave this scope like this. You can now hold the scope. अब आप rotate करोगे. Gently rotation of this way. Gently rotation. You've got CBD, right? Tip up. Tip up, yeah. I think it's very important to keep your tip up. Okay. So we'll now, and we keep doing rotation. Yeah. So now you've got the stent there. Can you see the stent? Yes, sir. Okay, good. So you can pull back, let go of your big wheel a little bit, tip down. That's it. So now if you go anti-clock a little bit, you can see the stent, and you can see this area there, right? Which is, yeah, and the PD will be visible in a second, but this area is what this is what you're talking about, and I'm not too sure. So I think the better place for this would be D1 in my opinion, and that's the pancreatic duct. So you've got both ducts, and this is the place where you can quite often see pancreatic duct going this way when there is pancreas divisum. Otherwise, it's going there, and both the ducts are going into the ampulla. Okay. If you go anti-clock now from here, then you should see. You don't fall back, then you would see the aorta, and then if you go more anti-clock, you'll see the IVC. But that's not what we are really interested in. We saw one lymph node, so we'll come back. Yeah.
Yeah, we saw one.
But I'm not too sure whether that's inflammatory or looks more inflammatory to me. This lymph node is parapancreatic, just next to the uncinate. So now what I do is I fall back, so you can keep coming. If you want to do what Khalid does, where he can fall back and start looking at the scope up, let go of it, because you want to take the scope out back into this. Yeah, you can go back to the and tip up, tip down, no. Tip down a little bit. Under jaye, you're out. Remember, what happens is, quite often when you will be doing initially, you'll be falling back into the pylorus without you realizing. And as soon as you go back into the stomach, the view goes away. As soon as you're in the bulb, you'll be able to see the whole thing. That's the portal vein. Let me just bring the cursor out. So that's portal vein. That's gastroduodenal artery. Okay. इसको दोबारा पकड़ें सर, आर्टरी पे रखें सर, अब दोबारा just get it there if you can. Yeah, just keep it there. So I'll show if we can where is the power, and we'll cursor को हटा दें. हाँ. Okay. So that's the waveform for artery, and that's the waveform for that's the waveform for a vein. That's the power Doppler. If you guys, hope you saw it and appreciate that.
Yes.
That's the function of the power Doppler. So you can differentiate between an artery and a vein. That's just part of the branch of the, tributary of that. So we go back. Now, you need to bring the CBT because I want to see what's happening here. Are you fallen back into the stomach? I have a feeling you might have. Yeah. Okay, the tip up, please. Okay, I need now. Doctor साहब आप मुझे जरा दे दें, मैं देखूँ FNA करना है. So there is one more lymph node here. Can you see that? And there's multiple lymph nodes here. These ones don't look good to me. Shanil?
Yes, we can see the lymph nodes here.
Now you see they are lymph nodes. Yep.
Yeah.
Okay, and they are dark. They are they're looking, this is liver hilum almost here. So we see some more here. Can you see that, Shanil? So there are multiple lymph nodes. I think that's what I had seen before.
Dr. Saad,
and there is one here.
Can you just show us the liver hilum again? And
I will just show you in a minute.
Thank
so
you.
We've got one large lymph node here. So we can take the cursor off, and if we want to, then we can quickly measure it. And pause. So we press the caliper button. You have this plus sign. Press the set button. You get the option there. Press the set button again. You've got 18 mm. Again, you'll have the plus sign for you. Press set following that. You've got the measurement, press set, you've got this. So that's how you measure the thing. Yeah, this also looks, this is quite big, but it could be inflammatory. Okay, so you want to go towards the liver hilum. So what we need to do for going towards the liver hilum is basically, you can see the liver on the left, and we can just keep following it. One way of looking at it is going using the D1 and going counterclockwise and basically pulling back. Because the stent is there, I think you can see that it's not so visible, but that's where we are. Did you see that?
Yeah. Thank you.
Okay. But the other place where you can see liver hilum is by following the portal vein. I'm just going to have a look at this area to see if I can do any. If FNA is possible, or I don't think I would do FNB here. Now, can I have FNA please? This whole area, area here is, what do you think, Shani?
It does look abnormal. The wall is uniformly thick rather than
And you
three
can't see the
layers.
layers.
Yeah.
So I'm going to go as close to the duodenal fall off as I can to see if we can get a better. FNA ready? FNA. I'll use FNA, not FNB. Why? I prefer, but I think I would go with FNA.
Sir, why are you using FNA?
Because it's a very small target.
Okay.
We have a stent in between.
Right.
So I'm trying to see what would be the best area where, because there is some debris in the CBD as well, you see. Not happy.
Sir, one question. That distal CBD very little and there is less swelling. So how would you feel that there will be good yield of FNAC or FNB?
I'm sorry, I missed your question. Okay, this is good. Sorry, go ahead.
Sir, basically we are confusing that lesion is looking very little. So what will be the yield of doing FNAC?
Well, we'll find out in a few minutes, but that is why I've been spending so much trying to see exactly where I want to go and see if we can get something out of it.
Okay.
But it is difficult. Doppler. Yeah. Yeah. Difficult because No, it's not hard. Doppler again. So this is my area where I really want to come, because I don't think this is debris, but we'll find out in a bit.
Sir, will brushing help us regarding as compared to FNC?
Would brushing help? What does the audience think? My experience is
Yield is very about 30-40%.
you have the option of intraductal biopsies, you can do it, yes. But I can feel that I'm getting some tissue here just by the feel of it. So I'm hoping that we'll get something out of it. The yield is actually, with Rose, is pretty good. We will be able to find out what we've got, and then obviously accordingly see how many passes we have to make. But you see, this is the area that I was targeting is तकरीबन खत्म हो गया. हाँ, गार्बेज अभी देख लेते हैं इसके बाद, लेकिन ये ख़त्म कर लें. I mean, as you would appreciate, it's much easier to take a specimen from this area. Okay, if I had to target this lesion, it would not be a problem. Okay, but this is not necessarily going to give us the yield. It's probably like the last one, which to me doesn't look malignant. So I don't know. That's why I'm not biopsying that. I'm rather focusing this area, which is, if I can show you, my area of interest in the duct is this area, where we have hypoechoic hair, the layers, I can't see anything about the duct, and this doesn't look like debris to me. When I went in, this was slightly, it gave me a feeling of tissue as well, so that's also something that you get. You see that better now?
Yes, yes.
So this is the area that is of interest to me here. So this patient is being done under sedation. We have given her 1 milligram of midazolam and 1 milligram of KINS, that's all. This is our normal practice. Most of our patients for FNA or FNB are done under sedation. Only therapeutic work, whether it's celiac plexus block, whether it's biliary drainage or pseudocyst drainage, that's where we actually use propofol more, or obviously in some patients there is where we have issue with
Sir, one question.
yeah.
While taking biopsy from distal CBD, is there any chance of perforation here?
No, we've already got a stent here.
Okay.
Unlikely.
If you don't have a stent in the CBD,
Then you may, but if you're going into the wall and if you see a mass, then I don't think that should be a problem. Something that we don't worry too much about. These needles are very small, they're 22G. So generally speaking, I have not. So when I see, you see, look at the needle here.
Sir, we can't hear you, sir.
I said, if you
Yes.
look at the needle,
Yes.
when I pull back, you can see the tissue comes back a little bit with it. Can you see that? It's
Yes.
stenting there. So that's what's telling me that we are where the problem.
Now good, sir.
Yes. but still not this.
Here again, can you feel that? And this is not the stent that's blocking me, or stent that's pulling me. So I'm pretty convinced that we are in the mass. We are in the tissue, and so let's hope we get some good tissue here. So no, when you've got a stent already in place, you don't have to think about it at all. If you don't have a stent in place, it's very unlikely that you would be something that we haven't seen that often. Because these patients usually present with obstructive jaundice, so they are usually already have had their ERCP before they was generally. So if you notice, my scope is straight, and once I've got my position, we try and maintain it. And be your
Sir, in such cases where we are suspecting the distal CBD malignancy, so still we are confusing the CT scan reports. So it is not better to go for endoscopic ultrasound in spite of going for a CT scan?
I think CT scan is very useful because it gives you a guide, but you can go for EUS first as well. CT scan would be nice in picking up liver mets.
Yes.
Any other mets, CT scan would pick up better than us, because we can only look at left lobe and segment 5, so we can't look at the whole liver, and can't look at anything beyond 5 centimeters generally speaking. So a lot of things are going to be picked up by CT scan that we can't pick up, because CT scan is a more holistic test and has advantages with vascular invasion, vascular involvement. So I think CT scan is useful, and to be honest, the practice generally is that when you have a person who has obstructive jaundice and they suspect there to be a problem with pancreas or CBD, mostly patients already have a CT scan and then they are referred to us. That's what we have seen.
Sir, if we come across a patient, can you hear me?
Yeah, I can.
If we come across a patient with obstructive jaundice and CT is suggestive of terminal CBD stricture, so what would you suggest to go first, ERCP or the EUS
Well,
guided?
if you have the facility available, then both at the same time.
Which one
Ideal.
is first?
You do EUS first.
Yeah.
You look at the lesion.
And if there is a need of
FNA, if there is a need for doing an ERCP, you just do the ERCP then and there.
EUS with FNA, FNB, whatever is required first.
Yeah. If you see a mass or a lesion, then you do FNA or FNB, whatever.
Right. Thank you.
For most good centers who have the facility available, they would go ahead and do an EUS first, immediately followed by Doppler एक दफा दे दो. Thank you. छोड़ दो. See, although we only have like a centimeter here, but I'm controlling it without the, so you can actually, if you hold the, if you look at my hand, we're just jabbing with the thumb and the index finger here, and using my other fingers as kind of a blockage, so it's not going beyond. Can you appreciate that? I don't know if you can.
Yes, we can.
Okay.
Dr. Sir, this is your third pass.
Yeah. So
Would you have used suction in this cases?
no, I have not had any feedback so far from the colleagues, but I know in this case I would certainly need 3 passes anyway.
Okay.
So I went ahead with 3 passes and now I'll stop. So now I want to know what, that's our own experience. I don't think in a lesion like this, my support staff will satisfy for anything less than 3 passes. बस खत्म हो गया अभी भी. 1 milligram Domio दे दे. Doc, you hold this for. Let me just go and check. हाँ जी, दिखाओ. टिश्यू आ गया. Cells, अब आप, while the patient is stable, so now come back, let's go back to the stomach. थोड़ा सा आपको वो जो आप पूछ रहे थे समझ वो हुआ, D1 वाला, हाँ? So a lot of things will come with learning. Obviously, you know, it will take time. The movements are very, very small, subtle. That is the key. The torque, straight scope, pull back now. अब थोड़ा सा पीछे आ गया, इसको पीछे कर लेना. आप जैसे मैं यहाँ खड़ा हूँ ना, अब यहाँ आए. Just come here. Right. That's it. Now, liver. ठीक है. So where are you now? We're still way in. तो पीछे करें. Right. Come back a little bit more. Little bit more. Little bit more. Okay. Keep coming. Keep coming. Keep coming. Keep coming. Keep coming. What is this? Stop. एक मिनट.
So I actually already told them.
अच्छा, you did. Okay. चलो. Okay, fine. So we have liver here. Okay. Keep coming back. Keep coming back. करें. नहीं, अभी थोड़ा pull back. Now rotate clockwise. Pull back. एक मिनट. Stop there. Okay. So let's see what that is. So you've got pancreatic duct above. Okay. जब अब आप चिल्लाएं ज़रा इसको राइट पे. See, this is what I saw when I was going in, so that's what I wanted to have a look. I'm not sure what. थोड़ा सा clockwise करें. थोड़ा सा pull back करें. See the lymph nodes there? एक मिनट ठहरें. थोड़ा सा pull back करें. Oh, sorry. Just go in a little bit. And
Sir, can you highlight the lymph node for the?
I'll just do that. Just 1 second. So you see one there. One lymph node there, and then I think that there is also a lymph node, so we need to bring it towards us. So we go in, go anti-clock and see what that is. Doppler attack. We also saw stent. Abhi up hanka. We're lost, right? So the thing to do is, just see. There's a lot of. Doctor, I'll have to take over. 1 second. I need to see what this is. We'll go back to the liver. You lost. So in the liver, when you're looking at the liver, we should be able to see. the ductal system is dilated. Okay. Keep following the liver here. Keep going right. Keep going right. Okay. We have another lymph node here. So we've got one lymph node there. There's a lymph node there, but that's a not so, yeah. You see, yeah, look at this now. No, this is not hilar area. This is most likely. You see the stent there? Can you see the air? So
Yes.
I'll tell you, these are all lymph nodes there we were asking about. When I told you I saw them, we were going in. Can you appreciate?
Yes, we can.
If I show you all this area, this is lymph node there, and this is a pretty ominous looking lymph node to me. Okay. This is, I would say this is, what area is it? This is pancreatic area. This is more, yeah. This is your portal vein, right? This is the portal confluence. Okay. That's your stent. Can you see the stent there? CBD there. There's the stent. You can see the CBD here. Can you appreciate the CBD?
Yes.
So you can see the CBD there, and you can see hopefully see the stent there in the CBD. It's dilated. Now you can see the stent better. So we are going towards the duodenum. If I keep going clockwise, we are going towards the duodenum. If I go anti-clockwise, I'm going now towards the liver. Okay, so I'll keep going, and that's another way of looking at the hilum. So you can see the CBD followed all the way into the liver, and the way you're doing is just a little bit of clock, anti-clock, but a slight pullback, and then going anti-clock, letting go of your big wheel as well while you're doing that. We're almost at the liver here. Okay, so that's your hilum there. Okay. Okay? Yeah, we are now in the stomach and looking at everything. These lymph nodes are obviously ominous here. She's definitely got malignant tissues. That's, anybody, what's that? Doc, what is this? What is this? What is this? है तो वेसल और ये भी वेन है. क्या हो सकती है? लिवर में है. Intrahepatic IVC there. ठीक है? And this IVC you can, if you keep pulling back, keep pulling back, keep pulling back, keep pulling back. I'm going a little anti-clock, pulling back, little and more anti-clock, pulling back, following IVC, letting go. So we follow it, and we've come to the heart there. That's the right atrium. Okay, so we can follow the IVC all the way to the right atrium. I think liver mein I couldn't see any. You saw the liver thing. Just have a look at the mediastinum, will come out. I think the area of interest here we have seen. So I would have my scope tip up a little bit. Yeah, you've got the left atrium, pull back. So you've got both the valves. You can see mitral valve, you can see aortic valve. You can follow aorta if you want to, but there is no need to. So just pull back, and tip up, pull back, slight clockwise rotation, slight clockwise, that's it. So now you have, that's it. So you have left atrium here, you have aorta here, and you have the subcarina, okay? And so you can look at the subcarina. So the way you look at it is you can rotate a little, so you will be able to see a little better there. You can see the lymph node, which we were not seeing before. Now you can, so you can see the subcarina by again rotating or moving your scope clock and anti-clock gently. So you can do that, and as you come out, I wouldn't bother with the AP because patients really become uncomfortable, but you know how to do it. You've been told. So all you need to do is for AP is you need to just have a gentle try. Let this hand go down, 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 and pull the scope back. As you pull back the scope gently, tip up, yeah. So we've got aortic arch. In fact, you've got the AP window there. Okay. Can you see that? Pulmonary artery on the left, aorta on the right. Yeah.
We can.
ठीक है? छोटे से होते हैं. Take air out and take the scope out. हाँ. Okay. It is not about completing the scope here, because obviously if you can complete this, then फिर कोई बात ही नहीं होती ना 4 के. It's about understanding the clockwise and anti-clockwise movement. It is about making sure your tip is up enough. It is about knowing what happens when you have tip up and what happens when your tip is down. It's also about knowing what happens when you advance the scope and when you pull back the scope. So this is your chance to understand those things. Once you've got the fundamentals, the pictures and things, obviously with experience, everybody will use. Simple things. My level of EUS you can reach very quickly. Beyond that, you have to work very hard.
It might